Many people start their talks with thanking their co-investigators, and I certainly want to do that. And when I have to thank my co-investigators, I really have to thank a lot of people. But there's some very interesting, very close co-investigators here. One is my brother, Dr. Cedric Garland, and our colleague, Dr. Edward Gorham, and Sharif Moore, who's a graduate student at UCSD. And another individual that I wanted to point out that's very special to me. As you can see, I'm from the Naval Health Research Center in San Diego, where I'm the technical director. I'm also on the faculty at the UCSD School of Medicine and also at the Moores Cancer Center. But I'm very fortunate today, one of the members of the audience came up to me and said, you know, my father was the first technical director of the Naval Health Research Center, Dr. Walt Wilkins. And she's here today, and she works in diabetes nutrition. So I'm very pleased to have her in the audience, and if she's anything like her father, if I say anything wrong, she'll stand up right away and let me know. So thank you. All right, well, if the mic is working, we'll move on and start talking about whether or not diabetes can be prevented. Now, we're going to focus, as I started to say, on type 1 diabetes, which is juvenile diabetes, which means that it's the diabetes that is most common in children. In fact, the incidence is highest between birth and age 14. The incidence continues on after that, but to a much lesser degree. Now, this is the kind of diabetes, it's also called insulin-dependent diabetes, because the signature sign of it is a disease that responds to treatment with insulin. So if you have a child with insulin with this condition and you give them insulin, the child responds very well. Now, insulin won't cure the disease, and these children live for the rest of their lives under the threat of vascular disease or kidney failure, blindness, and certainly one way or another a shortened lifespan. And in the United States alone, there's approximately 15,000 new cases of type 1 diabetes a year, and about 1.5 million children that are living with the disease right now. Now, as with most of my colleagues in this business, we don't have any relationships to disclose. Now, type 1 diabetes is categorized as an autoimmune disease of unknown etiology. Now, what that means is it's categorized as an autoimmune disease because what's going on is that your body, the immune cells in your body, do not recognize the cells that create insulin in the pancreas, the beta cells, as self, and they attack those cells, and kill them. And it's said to be of unknown etiology because there's no known cause for this disease, no widely recognized cause and no established cause. And because there's no established cause, there are no measures taken anywhere in the world to prevent type 1 diabetes in children. Now, this is the incidence rate of type 1 diabetes in Finland. Sharif Moore made this particular graph, and the points represent the actual incidence points in Finland of type 1 diabetes in children from age 1 to 4, or actually from infancy to age 14. And the line that's plotted is the midpoint between the years. So the line kind of gives you a feeling of the overall flow. Now you might say, why Finland in this particular case? Well, Finland has the highest rates of type 1 diabetes in the world, and rates vary widely by location. We'll see a little bit of that later on. But in looking at this graph, let's take a minute and look at it carefully and see what it can tell us. Well, the first thing an epidemiology does usually when they look at a graph or look at a statistic is it an artifact? Is there something that could have caused it that perhaps is not a real event? Well, that's not likely to happen in Finland because in Finland they have nationalized healthcare and they have superb registries. There's not likely to be a change in diagnosis over this time period because this disease is easy to define and easy to get correct as far as a diagnosis. So neither one of those are likely to be in play. So pretty much right off the bat you can lay out an artifact as not being involved. Well, let's take a look at what this graph might tell us about the nature of this disease in Finland. Well, as you can see, starting in 1960, on this graph, somewhere around 1964, they began to plot it and started to keep careful statistics. And there's a general rise from about 16 per 100,000 children to over 65 by 2005. And giving this what we like to call in epidemiology the eyeball test, there's a couple of things that emerge. It looks like there's almost two slopes. It looks like there's one slope that started perhaps in 1965 and goes up to the early 1990s, and then the rate of increase increases. If you can see that yourself. In fact, we're all going to be epidemiologists today because we're going to try to look at this together. But that's something that I think stands out. And as Dr. Gorham pointed out, we're very interested in time, place, and person. And this is a time series. There's 3 tools that epidemiologists use to find out the cause of a disease, and they start with time. So this is a time series, and there's usually information in it that we like to use. So what I'd like to do with this is, as we look at it, we can see that it is, in fact, an epidemic. And an epidemic, to an epidemiologist, is something that has to be halted. And another thing that an epidemic is that it's a public health mystery. And the question that we have facing us is, can we solve this mystery? And I'd like to step through this together and see if we can solve this mystery, and also see if it has the fingerprints of a vitamin D deficiency disease on it. Well, if you're going to solve the mystery, one of the best places to start is at the scene of the crime, or the scene of the mystery in this case. And this is an islet cell that I was talking about. This is the cell in the middle of the, here we go, in the middle here. That's an islet of Langerhans. It's in the pancreas, and some of the cells in there produce insulin, and insulin is required for your body to metabolize and to use glucose properly. This is a healthy cell. Now this is a picture. Ignore these 2 bodies there. Those, I think, are blood vessels, and so they appear clear. But right here is one of those islets of Langerhans, and you'll notice that it's full of black cells. What's happened in this case is that the immune cells of the body, the beta cells, T cells, and macrophages, have gone into the islets of Langerhans and killed and destroyed the beta cells and replaced them utterly. That's why it's called an autoimmune disease. In this particular Langerhans area here, there's still some cells right there that are still pink and are still able to function, but about 60% of it has been wiped out by the person's own immune system. Well, if the triad of epidemiology for solving a disease is time, place, and person, the way that we approach studying of a disease is through another triad, and that's the triad of disease causation. And that includes host, agent, and environment. Now, host factors can be as basic as the basic genetics of the individual and some susceptibility that goes along with that, or something that's been altered in the host. For instance, having a vaccine for a flu, or some other thing that can change a host status in terms of its susceptibility to a particular disease. The next issue is an agent. Most diseases require some sort of an agent, whether it's a virus or a bacteria, or in some cases a chemical that can cause a very serious disease. And lastly, the environment. The environment, and we talk a lot about geophysical factors in our studies of vitamin D. The environment is very important. It can be as small as the room you're in terms of its temperature and humidity for spread of infectious disease, or as broad as the geophysical factors that we often talk about when we're talking about vitamin D. Well, let's go back and start with the host factors in terms of genetics, the most basic question. Well, here we are back at the mystery that we're looking at and that we're trying to solve. Now, often you'll hear almost for every disease that there's a genetic component, and there may be some sorts of susceptibility. Some individuals with particular HLA types, for instance, are a little bit more susceptible to type 1 diabetes. But is it logical to think that you would have a genetic change in a population like those people living in Finland over this time period that could lead to this much disease? It's really not a logical idea that there would be a genetic change at a basic level that could lead to that kind of an epidemic occurring in a single population. Let's take a look at agent. One of the hypotheses that captured the imagination of the medical community, and one that is still widely held, is that this disease results from an infection from a virus. And one of the viruses that's included in the disease-causing viruses is a picornavirus, a Coxsackie B virus. This is one of the papers. It was an early paper, but it was one that helped set the stage for this theory grabbing hold. This is this is in Norway. Now, the countries where the best epidemiology has been done, and probably the most epidemiology on this disease, happen to be the countries like Finland and Norway and Sweden. Those are also the countries that like to publish these works in a journal called the Journal of Circumpolar Medicine. So you can imagine how focused they are on certain of these issues. Well, that's a clue right there, by the way. In this particular case, there was a coronavirus outbreak in 1983, and these authors showed the relationship over time to the incidence of type 1 diabetes in this population. Well, I must say that as far as I can tell, the disease was actually rising before there was the coronavirus outbreak, and then if anything it went down a little bit or just evened out. So in fact, this is a theory. It's one that's widely held. There's no identified agent for it. You can't find this agent in the Langerhans cells in the area, but nonetheless, from a pathological viewpoint, it might be something good. Something caused a change in those cells, those beta cells that create the insulin, that then the body didn't recognize them anymore. So it could be some kind of an agent, and maybe it's a common virus. Maybe it's a adenovirus or a measles, German measles, or some other thing. But let's say, okay, we'll go with that. You needed some kind of a precipitating agent, and perhaps it's a virus and perhaps it's a common one. Now let's take a look at the top of the triangle, which is environment, and we'll go back and take a quick look at our graph here and note again that we do seem to have an inflection point somewhere around 1994. Well, the people in Europe, in Northern Europe, got very concerned. And of course they got concerned. I think if you had this sort of a situation going on in a number of your countries, most notably in Finland, but there were other countries in the area, they became very concerned in about 1988 and began a massive study where they enrolled in about 45 different registries in a wide range of countries in Northern Europe. It also happened to include Israel and others in what they called the EuroDiab study. And it's a major, major study to look at influences on type 1 diabetes. And it was started in 1988, as we mentioned, and it used 45 registries, and they enrolled about 16,000 children under the age of 15. And they noted, as we just saw in that other graph, that there was a rapid increase in the cases of type 1 diabetes. And this is one of their first analysis. We call this a cohort analysis. It's not a cohort study, but it's a cohort analysis. And these are the different age groups. These are boys in all of these countries. This was published in Lancet in 2000. And what this shows is that the younger children at ages 0 to 4 have a more rapid increase than the older children. Now what you're seeing there is that upturn that we saw around 1994, because the younger children are getting this disease at a more rapid rate. And what it tells you is that while it's going up in the other groups, there was something that happened to those younger children that was more indicative or causing this disease to a greater extent. And the phenomena is in both children that are men children, babies, males, and this is the same sort of analysis for females, or maybe I had it the other way around. Yeah, this is girls. All right, well, when should you, as an epidemiologist, or even as a clinician of any sort, start to suspect that you may be looking at a vitamin D deficiency disease, or possibly even an individual that's vitamin D deficient? Well, as I mentioned, Finland has the Journal of Circumpolar Navigation, and I considered that a pretty good clue right to begin with. But if the disease you're looking at varies by latitude, it's highly likely to be a vitamin D deficiency disease. And we've seen this with the cancers and multiple sclerosis and a number of things. It will tend to vary more by actual ultraviolet irradiance than it does by latitude because of things that we've discussed, Bill Grant's work and Edward Gorham and others, where ozone or air pollution can decrease the transmission of that very small part of the spectrum that creates vitamin D in the skin. So it should vary more by irradiance than by straight latitude. It varies by season, and the reason for that is because the seasons, there's a different amount of sunlight available, and it very often will vary by race, BMI, or physical activity. Well, let's step through some of those and see what kind of information we have. As far as a variance by latitude, this is the rate in Rochester, New York versus San Diego. It's 10 times as high. Type 1 diabetes is 10 times as high in Rochester, New York as it is in San Diego. And as you know, those are at very different latitudes. Now, when they started the study in 1988, the Europe... Yes?
Could that be right? You go back to the slide before. Can that be per 100,000? That means there's hardly any cases, and I know it's about 1 in 500 type 1 diabetes. Is the rate there? What am I missing here?
Well, that is the rate per 100,000 children, so it's...
So it'd be like 20 would be 2 per 50,000, 1 out of 25,000?
Yeah, per year.
But the increase, wait.
No, this is the annual rate in these two cities per 100,000 children.
In this country, it's 1 in 500.
Is what?
1 in 500.
Well, there's a great variation of the rate, so I'm not sure what it is for the total U.S., but somewhere in between here possibly. But new cases per year. All right, good. Well, you're thinking of prevalence maybe? Or you're thinking of prevalence. That's like 1.5 million children in the U.S. versus 15,000 new cases a year. Okay, good. All right, now when they started the Eurodiab study, they were really on the trail of a virus as the cause. So they present this in the paper. These are the countries that are in that very large study that we were talking about that was begun in 1988. And what they did here was, and they discussed this in the paper, they had the choice of either presenting in the paper the countries by latitude or by temperature. And they chose temperature because they felt that that might be an important factor in terms of transmission of a virus. And that was an interesting idea. But I decided to put this one here because if you look at it, you'll notice Finland, Prince Edward Island, Sweden, Norway, that's a high area. I think that's Rochester, New York, versus Cuba and Israel and the typical areas that we see. So temperature and latitude are highly related. But we think that probably what you're looking at here is more a relationship by latitude. And one of the reasons that we think that, this is a study done by Sharif Moore and our group here in San Diego. This is an analysis of the incidence of diabetes with some new data that just recently became available for 51 countries. And this is, I think it was Senator Garland that mentioned that this is what we call the vitamin D smile. And it's a bit of an unusual presentation, but the reason why we chose this presentation, this is the equator, and this is as you go north of the equator, and this is latitude as you go south of the equator. Because the Earth is round, you get this effect on both sides. So what this kind of display does is it shows you that the effect is occurring both on north of the equator and south of the equator as you get further away from it. And if it is related to latitude, the particular disease that you're looking at, you will see this kind of a pattern that emerges. Typically, most of the time these things are just presented as a straight line, but that's one reason why we do it this way. Now these authors then took the same data and they adjusted it for cloud cover. And the reason why they did that is clouds are very effective at blocking the ultraviolet part of the spectrum. And this, when you adjust this latitude for cloud cover, you get a much tighter correlation than is even presented here. So we've got a pretty good, clear indication that this disease varies by latitude. Now we were talking about season, and it was referred to a couple of times already about the NHANES 3 study. This is a treasure trove of the understanding of vitamin D because what they did in the early 1990s, they go out in trailers and they took a random sample of the United States and they have thousands of samples that they've taken of blood and they can analyze that blood now for vitamin D, and that's been done. And interestingly, a paper was published not that long ago using the NHANES data, which is more or less publicly available, and the paper was done by a nephrologist actually working with an epidemiologist. And the reason was nephrologists are very keenly aware of vitamin D status in a human, and they're almost more interested in vitamin D than say, just regular epidemiologists. But what we see here is this variation over time by season in your risk of being deficient. That's what this is showing. What is your risk of being in the very lowest quartile of the population by season? So your risk, if we set the risk at 1 in winter, you have a little lower risk. In the summer, you have a very low risk of being very low for vitamin D. So this is the bad one. This is the winter shows that you have less people with the population with high levels of vitamin D. And as was mentioned by Edward Gorham, this is an underestimate because the way they do the NHANES study is during the winter, they go in the south because they don't want to go up in the north and get stuck in the snowy roads and all of that sort of thing. So this is very definitely an underestimate, but it's a logical one. They weren't really going out to get the story on vitamin D. But if you see a disease that varies by season, that might be a clue that it's a vitamin D deficiency disease. Now, we had an opportunity just recently to look in the Department of Defense for the rate of type 1 diabetes. And while type 1 diabetes is most common in children from infancy to age 14, it still does continue on throughout life into the 30s and 40s. We're not even sure sometimes how much is misdiagnosed later in life as type 2 diabetes. But we looked in the Department of Defense, and it's a wonderful laboratory for studying this because before you're allowed into the Department of Defense, you have to have a test. And if you have an abnormal glucose test, you're not allowed in. So we start with a population that we know is disease-free, at least as much as we can verify on one test, disease-free from the incidence or from having type 1 diabetes when you enter the service. And we were able to plot by month the rate of new cases of type 1 diabetes that occurred in that population. Now, the amazing thing here is that we're talking about something that's considered a chronic disease, not necessarily an infectious disease, and one that once you get it, you have it for the rest of your life. But interestingly enough, and what we did was we highlighted on this graph, the highlighted months are July. And what you can notice here is that there's a very definite pattern. This is number of new cases in a fairly stable population. These kids are between 18 and 35. A seasonality pattern where it's much more common to have a new case diagnosed in the winter than it is in the summer in the Department of Defense. Now, I can tell you another thing about that particular slide, but we'll go back to that. But let's take a look now at race. So many diseases vary by race, and this is again NHANES data on the risk of being in the lowest quartile in the United States population if you are white or black or Hispanic or other. If you're black, you have 10 times the risk of being vitamin D deficient as another individual. And the reason for that, and some of this has been studied in great detail by Dr. Chen and Dr. Hollick's group, if dark skin exposed to the same amount of ultraviolet radiation is very slow to make vitamin D. And I couldn't go into the details as well as Dr. Hollick, but it has something to do with how far the ultraviolet can get through the skin to convert to vitamin D, to pre-vitamin D. So you have a very high risk of being vitamin D deficient and in the lowest quartile if you're black. Now in the Department of Defense, blacks have 2 to 3 times as much type 1 diabetes as do whites in that population. And I'm sure many of you can think of a disease that you're dealing with and a disparity in a disease that's often attributed to some unknown factor. Well, it's good to start thinking about vitamin D because of this very, very high risk of being deficient in vitamin D if you're dark pigment, if you have a dark pigmentation. Now this is another one. This is less relevant to this particular disease. This happens to be body mass index. That's how much you weigh compared to how tall you are. And what this shows, and this was mentioned earlier again today as well, those with the highest, those who weigh the most for their height, have the highest risk of being in the low vitamin D category, in the low vitamin D quartile. So if you're looking at a disease, and this particular data is cross-sectional, so we don't know necessarily if this is a cause or effect relationship, but it's definitely a relationship. So if you're looking at a person with any of these characteristics, they're more likely to be vitamin D deficient. And lastly, this is the risk of being vitamin D deficient if you have low exercise versus more physical activity. And these are key elements for a couple of reasons. One, they help us understand a disease, and if we start to see patterns that follow these patterns, we might be looking at a vitamin D deficiency disease. And another reason why they're important is that epidemiologists often adjust for these particular categories when they're looking at vitamin D. And that can be problematic because if you're adjusting for a factor that's highly related to the factor that you're looking at as a causal one, you take away some of that power to identify the causal factor. Well, let's go. We've done time, and we did place. Now let's look at person. Now we're going to go back again to Europe, where the best studies are done on this. Now this was a study that was published, and it's a meta-analysis of pooling together information from registries in these 15 different countries. And when they pool that information for exposure to vitamin D supplementation, just a very broad category, in childhood, this is what they found. The overall, Bulgaria here stands way out. There was very few cases. That was really a very much an outlier. Those are error bars. So if you go over the one, you're not statistically significant. But when you pool all of these areas, what you find out is that the odds ratio is 0.67, and it's statistically significant. So that's a 33% reduction, a 1/3 reduction in this particular set of countries if at any point in childhood you were exposed to vitamin D supplements. And that's a pretty powerful effect. You know, if you can reduce something 33%, that's pretty good. And it wasn't a real strong study. I think it was a case control study, but it's very indicative of starting to look at individuals. Well, it turns out there's really only one study that looks specifically at serum levels of type 1 diabetes at the time of diagnosis. And that was a study that was done in Norway. So the question is there a difference in vitamin D levels, serum 25-hydroxyvitamin D, at the time of diagnosis if you have type 1 diabetes? And the answer is right here, and that is yes, the patients, the type 1 diabetes patients had a level of 82.5, and the control subjects 96.7, and that's statistically significant. So we have a very important study because it's the only one that shows serum vitamin D, but it is cross-sectional. It's cross-sectional at least in terms of at time of diagnosis. If you follow these individuals out over time, their vitamin D level continues to go down and down and down in the case group. Well, moving on into Norway, one of the other good aspects of the European study that involved multiple centers was that there have really been very important sub-studies that have been done in some of those major countries. And we'll be going back to Finland in a minute. But Norway and Sweden are the two locations that have done the most epidemiology on this particular disease. So in Norway, they decided to look, and this is a case control study, look back and ask mothers, did you take any cod liver oil when you were expecting your child? And then later on they asked, did you give any cod liver oil to the children? So this was the answer to that. If one is set as no cod liver oil, if the mother took cod liver oil 1 to 4 times a week, her relative risk was 0.89, but it's not statistically significant in this case. And if she took cod liver oil more than 5 times a week, it went down to 0.67, and it's a borderline significant. So it's not quite significant, but it is in the right direction. And it's of the mother taking cod liver oil. And there's several things we know about that. We know cod liver oil might not be the best source of vitamin D because it has a lot of other substances in it, vitamin A and so forth, that make it maybe less available. And it was the mother, not the child. So the next question they asked is, well, did you give your child supplementation with cod liver oil? And this is what they found. Well, if the mother gave no cod liver oil to the child, and we set that relative risk at 1, that odds ratio, for 1 to 4 times a week, the odds ratio drops down to 0.7. That's very close to that 0.67 we saw for those other 16 countries for available, or that was 7 countries for availability or exposure to vitamin D supplements. And here we go, more than 5 times a week, the OR drops to 0.65. So in this case, if the child was supplemented during the first year of life with cod liver oil, you do have a decreasing dose response, and both the 1 to 4 times and the more than 5 times is statistically significant, as is the trend. So you know, this is very strong evidence that supplementation with cod liver oil during the first year of life reduces the risk in a dose response way in follow-up of these children. Well, Now Finland, and we talked about how they have the most serious problem, and they took this problem very seriously, and they took it very seriously early on. And as we mentioned, they have standardized record keeping in the country. They have wonderful registries. They have typically 10 visits per child. If a mother is going to give birth, she gets enrolled in a system, and then there's usually as many as 10 visits during the first year of life, and they can follow these children throughout their lives, and they did. And what they did was they established a birth cohort. They found women in Finland, 12,000 of them, who were to give birth during 1966, and they enrolled them in this long prospective study of which they would ascertain information related to exposures during that first year of life for those children and follow them up for a variety of diseases, bone diseases, but also for type 1 diabetes. So these 12,000 pregnant women and their children were followed for 30 years, all the way to 1997, for the incidence of type 1 diabetes. What did they find? Well, this is what they found. In Finland, if you were an infant and you were followed for 30 years and your mother gave you vitamin D as a supplement irregularly as a child during that first year, your risk of type 1 diabetes dropped from, if we set this at 1, it dropped to 0.16. That's more than 8 out of 10 cases that didn't occur in that group because they were supplemented, and it's statistically significant. And if she was a little bit more energetic in supplementing you with vitamin D, and we don't even have a dose here, but whatever it was they were giving at that time, the relative risk is 0.12, and it's statistically significant. This is a drop of 90%, 9 out of 10 cases. That's remarkable. We very often in epidemiology, you see relative risks of 1.1 and 1.2 and 1.3 and 1.4, and people are making a big deal out of it. This is a relative risk of 9 and 10. It's almost flabbergasting. Yes?
The dose is 1,000 units a day.
All right, wonderful. We have good. That's a key piece of information. And we'll go back to that notion of dosage in a bit, because that's very, very important. This was another analysis of those same children, and here, and maybe a member of the audience can help fill this in a little bit, but this was a low dose. This was vitamin D supplementation dose, what they considered low at the time, recommended, and high. One of the problems with the recommended, and we'll get into this later, is the recommendation changed over time. So, 1,000 we can say is a good midpoint on all of that story. So if they were getting the recommended amount versus no supplementation with vitamin D, 8 out of 10 cases were prevented for a relative risk of 0.2. And if they were getting a little higher dose, we're back to this 0.14. That's more than 8 cases out of 10 prevented in a long-term, 30 years, prospective study of over 13,000 children in a country with wonderful health care that can really establish a relationship like this with more than 90% follow-up, almost no loss in terms of disease incidence and mortality. Yes?
Was this just during the first year, the vitamin D supplementation?
Yes. This was just vitamin D supplementation during the first year. Now, they ascertained vitamin D supplementation during the first year. Whether or not the child that was taking it in the first year took it in the third or the fourth or the fifth, that's unknown, because this data happens to be just for children who were taking the supplement during the first year. Well, now the question may come up, well, how can vitamin D have this kind of an effect, have such a powerful effect? We know that vitamin D has effects, many cells, almost every cell in the body literally responds well to it. Now, Cedric Garland mentioned earlier today about the role of vitamin D as something very basic in a multicellular organism. That's how we see it. And it has many different activities, but one that we think is the main activity, or at least we're proposing it in this case. No one knows the absolute mechanism of this, but it's a likely one. And that is that when you are replete with vitamin D, your cells are well connected to each other, and cells that are well connected to each other communicate with each other, and they have a very powerful barrier function. That's what your skin does, or other cells in your body. They have a barrier function to keep out one kind of an invader or not. If you become very low in vitamin D, the cells tend to separate. And a number of things happen. One is that de-evolution because the cell is on its own. And another thing that we think can happen is when it separates, you open up a gap between cells, and that can allow different things to go through, whether it's an antigen or whether it's an immune cell. There are other things that vitamin D does independently. For instance, it's considered an immune modulator, and maybe it has some effect directly on the immune cells. But let's look at this in terms of sort of the combination of what we learned. One, that there might be an agent, it might be a virus, and two, that vitamin D is very protective, unquestionably protective. In fact, for causation, you usually need in epidemiology a couple of different factors. One, you need a temporal sequence. And we definitely have a temporal sequence. In that 30-year study, or in the one in Norway, that exposure to the vitamin D was before the development of the disease. And that's almost universal in most studies of vitamin D. We can get pre-diagnostic serum, or at least when we can, we really like it, because that gives the temporal sequence. You have to have the exposure before the disease. Another thing that you have to have, or you like to have, is a consistency of association. That's why we look at different populations when we can and see something. You like to see a dose response, if that's at all possible. And we have a dose response. In this case, the literature isn't replete with a lot of studies, but the ones that are there are very clear, and there does seem to be a dose response with vitamin D. So most of the characteristics, or in fact all the characteristics for causality, there's a couple of other characteristics. One is strength of association. You can't get much stronger in anything in medicine and epidemiology than a reduction by 80% with an exposure to a substance. That's like a relative risk of 10 going the other way. Very, very high, so you have a very powerful association. And lastly, one of the things that's sometimes included in causation in epidemiology is specificity of the effect. Well, that doesn't count for vitamin D because almost every cell in the body reacts to vitamin D, and as we know, there's a lot of diseases that vitamin D affects, so that one is not relevant to vitamin D. Well, anyway, looking at this, if we just want to go along with this proposed idea where you have a lumen of a cell, I mean of an artery or some kind of a vessel, and you have a very tight capillary endothelium. The cells are closely aligned with each other. That barrier between the cells, they're talking to each other, they're behaving properly, and there's a good strong barrier, and they're keeping out invaders. You get vitamin D deficient, and this otherwise good barrier, this vascular barrier, opens up. And to begin with, in one case, what might happen is it opens up to the point and it allows an antigen, in this case a virus, to creep into the Langerhans cell area where it shouldn't be, and perhaps infect those beta cells. And then the infection is over, but the body doesn't realize that it's over, and the body continues to attack and kill all of the beta cells that create insulin. That's the one thing we know about this disease, is that definitely pathology, and that is that you know, you are killing your own beta cells, your immune cells are killing your own beta cells. If you also don't have a good barrier because you deplete in vitamin D, it may also allow these other cells that don't belong in the Langerhans area, in the islet, the white blood cells and other kinds of leukocytes, to invade more freely. And that may be one reason why, one thing about type 1 diabetes is it can get worse and it can get better, and it can get worse and it can get better, and that's been somewhat for unknown reasons. Well, it may be that some of these barriers are fluctuating in terms of how effective they are as a barrier depending on vitamin D, and that's why we see seasonality in this particular disease. Well, let's go back now and take a look at the information and what we had here. And this was our initial mystery. This is our epidemic, and it's our epidemic that was slowly climbing here, and then the rate of increase increased. And let's see if what we found out and what we now know about the possible role of vitamin D can help explain this particular mystery. Well, very interesting thing was occurring in Finland during this time. At the very beginning of this epidemic, in 1964, the recommended amount of supplementation for infants in Finland was 4,500 to 2,000 international units. Now, the reason why that's so high is because, as we were talking about, that country is at extremely high latitude, and so they can make almost no vitamin D from exposure to sunlight, and that's certainly true for most of the year. So they've always been very alert to the need for vitamin D in their diet, and they would routinely and recommend fortification at that level. They then dropped the level from 4,500 to 2,000 IU right there in 1965. And that's when this epidemic started to go up. In 1975, and I suspect there's someone in this audience, probably Dr. Haney, could tell us why they made these changes over time. But it was, you know, people have lost interest in vitamin D, thought that there's no such thing as adult deficiency, and thought the only problem was rickets over time, so the interest began to wane. And when you see the interest waning, you see the dosage recommendations going down. So as we're climbing up here, when they dropped it to 2,000, right around here they dropped it to 1,000 international units. And someone in the audience already pointed that out. And the epidemic continued to rise. Now what we noted in the first time we looked at this graph was this increase in rise right there. And there's an inflection point. And that inflection point is right there in the early 1990s, and that's when they dropped the recommendation for vitamin D supplementation in infants in Finland to 400 IU per day. And you can see what that did to the epidemic that was occurring. Yes?
How were infants in Finland getting most of their vitamin D? Was it through cod liver oil, or how were they actually getting it way back in 64 and 75?
Well, that's a very good question. This was the recommended dose, and I don't think, I know that cod liver oil was commonly used in the area. Does the person that knew that it was 1,000 IU want to make a comment on that? Yeah, I'm not sure about that, but that's the recommended dose. And we know that some used cod liver oil, but also there was widespread vitamin D supplementation, just as D3 in the country at that time. Now, given this, and given that this country was so interested in this, and given what we know, and there's this wonderful researcher, Hyponen is her name, and she was the one that headed up the studies, the 30-year study of the infants, and had this particular finding that more than 8 out of 10 cases could be prevented by supplementation with vitamin D, and they did that very wonderful study. Well, unfortunately, her conclusion and the conclusion of those authors was that we suggest that before any changes are made, health workers ensure that all infants are receiving at least the amount of vitamin D indicated in the current recommendation. And that current recommendation was 400 IUs per day, right there. So we're not going to make that same mistake today. Yes, question?
Well, in these other years, do you know, this is just a recommendation. There is no way to know if they were actually taking this.
Well, that's a very good point. And one does wonder about that, because do people just instantly change, and there's you'd expect a period of, you know, maybe easing off, and do recommendations change that quickly? I think that, you know, I have discussed this with people, and because it was infants that were given the supplement by the mother and by the pediatrician under care, recommendations get taken pretty quickly and pretty importantly, unless, you know, in that particular setting, more than they would, like, you wouldn't even know if a recommendation changed perhaps in the US for an adult population. But it's thought that the recommendation was, you know, covered pretty quickly and followed pretty quickly in this particular population. And, you know, that's an inflection point. You know, I tend to think that it's a piece of information, and that, you know, that epidemic won't go down. Well, as I said, this was published in 2000, and not in, or actually not that one. This finding was published not in an obscure journal, but in the Lancet in 2000, that you could reduce it this much. And yet there's still been no action taken, and partially because the recommendation was that 400 is apparently enough. Well, that was said before, but I don't think that's going to be enough. We don't want to make that same mistake, because if we want to slow down that epidemic, which is our job as epidemiologists and as health advisors and providers and researchers, why not go with these recommendations? To reduce the burden of type 1 diabetes in the world at a minimum oral intake of D3 at 30 degrees or higher. Now, what the current recommendation is for infants, the no adverse level is 1,000 IU per day. Or that's the National Academy of Sciences upper limit, is 1,000 IU per day. So you can recommend right now 1,000 IU per day and be within that upper limit of the National Academy of Sciences. The actual no adverse effect level is 1,800 IU per day. So there's at least 1,000 IU there of a safety factor. And that's for actually children from birth to 12 months. Adults, the 2,000 that we've talked about repeatedly here and that D Action is going after, and in children 1 to 12 years, 2,000 IU as well, with a serum target of 40 to 60 nanograms per ml. Probably one of the best ways to deal with this is what's currently being proposed, and that is to actually do serum measurements and get them up to a level somewhere between 40 to 60 nanograms. Well, now what would be the risk-benefit ratio, for instance, of 1,000 IU for infants in terms of type 1 diabetes? Well, if that's a no adverse effect level, and you have the possibility of preventing 8 out of 10 cases, the risk-benefit ratio is infinitely large. And in fact, most of the diseases that we talk about today, because there are no adverse effects in adults at all at 2,000, the risk-benefit ratio is almost infinite. Any questions on this disease? Yes? Okay.
What adverse effects have been noted above those?
Yeah, that's what I was just going to ask.
What was the question?
What were the adverse effects above 1,800 when originally we were getting 4,500?
Well, again, I'd throw that to Dr. Haney or others, but I couldn't find in the literature, and I looked for it, any adverse effects reported from Finland with 4,500. But we, at this level of our state of knowledge, in order to fit within the guidelines that are currently acceptable by almost every organization, the National Academy of Sciences, we stay within those guidelines because they are quite a bit higher than what's currently done. Yes?
Does the National Academy of Sciences have a no adverse effect for a nanogram per milligram serum?
Yes. We could do the conversion for you. You mean for a serum level?
Serum level?
Yes, it does.
No adverse effect?
Yeah, what would you say that is, Dr. Haney? And then,
We can.
okay, okay. Aren't asking the right way, okay. Yeah, Dr. Haney will answer that one. He's the real expert.
No, what the National Academy of Sciences did is establish 25-hydroxy-D as the functional status indicator, but when they set the no adverse effect level, they were talking only about an oral dose. There was an inconsistency. We took step 1, but we didn't take step 2.
Yeah, your graph that shows an increase around 1994.
Yes.
Was there any looking at that in terms of immigration into Finland from points
From
south?
other places? Yeah.
Africa or Southern Europe or something?
Well, that would fall into that category of some kind of a change in the population. And there was that, but that was, I don't think that played a big role in this, but I'll look into it a little bit more. Okay, thanks.
Thank you very much.